At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. I am Donna Cryer. I am your host for this episode of GLI Live. And each November, we are so excited to celebrate Diabetes Awareness. Why, you ask? Might a liver organization be celebrating or commemorating or recognizing Diabetes Awareness Month? Hopefully, by the end of this episode, you will know exactly why. So to help me decode that question, that puzzle, is the perfect guest. I have with me today Dr. Brent Tetri. He is a gastroenterologist, a hepatologist, internal medicine specialist. He's everything. He's just everything. He is at SLUcare in Missouri. And welcome, Dr. Tetri.
Donna, I'm very excited to have this time to chat with you. You've done such great work with these series, and I'm very impressed. So congratulations to you on your outreach effort. Splendid work, absolutely spectacular.
Thank you so much. We enjoy far more than we anticipated when we started this during COVID, this opportunity to talk to experts from around the world and to be able to channel all the questions that we get from patients directly to folks like you. On this issue, we've had the opportunity to speak to endocrinologists like Ken Kuzi, who I know you know well. So we understand a little bit about how endocrinology thinks about the connection between diabetes and liver diseases like NAFLD and NASH. But we haven't had the opportunity to ask hepatology how they feel about that. So let me ask as perhaps my first question: what should liver patients be asking their doctors about diabetes? And then what should people with diabetes ask about their liver health?
These are great questions, Donna. And, in clinical practice, we often put the blinders on and we just focus on the one problem we're dealing with. And what you're challenging everybody to do is to be a little bit more holistic, or a lot more holistic, and view the patient as a whole, and consider all the ramifications. And actually, in my practice, I try to do that a lot. I try to be aware of all the comorbidities, as we call them, the other disease processes, the coronary artery disease, the elevated lipids, the risk of diabetes, the actual diabetes, because we do see a lot of overlap. And as you mentioned, Dr. Kuzi is an expert in that area. He's actually a hepatologist in hiding. He calls himself an endocrinologist. He's a pretty darn good hepatologist too. So in the context of fatty liver disease, we know that that's a major risk factor for either having the type 2 diabetes or developing type 2 diabetes over the course of life. And the reason for that is underlying both processes are probably the same disorders, the genetic and epigenetic and environmental causes that contribute to both. And that's why we see a lot of overlap between the two. And so as hepatologists, as liver specialists, and as patients seeing liver specialists, the important questions to be asking are, am I at risk for diabetes if I have fatty liver disease? And the answer is absolutely yes. And so it's incumbent upon us to be aware of that and to screen patients for type 2 diabetes, which is pretty straightforward to do, with hemoglobin A1C measures. Or more formal testing than that, glucose tolerance testing. And likewise, the flip side of that, when folks with type 2 diabetes are seeing their primary physician or their endocrinologist, as you mentioned, they should be asking, well, what about my liver? Is this going to be a problem for my liver? And People just have to be paying attention to a couple of things. One is the liver enzymes, what we call the ALT and the AST. Those are proteins in liver cells that get released into the bloodstream when there's damage going on in the liver. And, they can often be at elevated levels, not always, but often elevated levels when there's damage going on. And they're checked on just routine blood tests, what we call a complete metabolic panel, which is done fairly routinely. So it's not an unusual or strange test to do to check liver enzymes. And the other way we often pick up something going on in the liver is by imaging. So folks will have CAT scans or ultrasounds or MRIs for a variety of reasons, looking for gallstones, looking for kidney stones, whatever. And the radiologist might comment that there's fatty liver in there. And about a third of adults have fatty liver, and quite a few children do too. And if we see fatty liver or we see elevated liver enzymes in the context, in somebody who has type 2 diabetes, then we really have to be looking a lot more closely at the liver, find out what's going on. So those are the questions to ask. Hey, is my liver okay? Do I have fatty liver? Are my liver enzymes elevated?
So, when I talk to my friends who have diabetes, type 2 diabetes, or who lead online forums or other outreach or support groups for people living with diabetes, none of them have ever heard about NAFLD or NASH. And yet the literature suggests that up to 75% of people with type 2 diabetes might be walking around with some level of fatty liver disease. Why the disconnect?
Yeah, this has a lot of historical reasons, I think, and it's really a problem. People are told, oh, it's just fatty liver. It's like, it's no big deal. It's really common. We don't see the problem. Well, as hepatologists, we see the problem because, as you know, fatty liver disease, the NASH, the folks with NASH, which is the more damaging component of fatty liver disease, are at risk for progressing onto cirrhosis. So it's an educational thing. And by golly, we try really hard to educate our colleagues, the primary care physicians, the endocrinologists, and everybody else who might be encountering these patients. But it has permeated the system for so long that it's a benign process. It just takes a lot of educational effort to get around that. Another aspect you might not be aware of, but I see, is that radiologists, when they read scans, when they read a CAT scan done looking for kidney stones or whatever, they might see fatty liver. But it's so common that I often see that they don't, I don't know how often, but it happens that they don't report it in the report. They don't say anything. Just because, it's just fatty liver.
So we call that incidentalomas, I think. And there have been some patients who have gone back and noted that they did have indications on imaging, maybe even a note in the fine print in the bottom, but nobody reacted to it. Nobody said, oh, this is something that we need to follow up on and do, XYZ next steps. They're more often, if they're told anything, just like you said, don't worry about it. And then they end up, unfortunately, next being told that they need a transplant or have liver cancer because, a decade later or sometime later, it has progressed and it is life-threatening.
I can't tell you how many times I've had the conversation with patients in clinic, come to me with newly diagnosed cirrhosis. To me, obviously, it's NASH cirrhosis or fatty liver disease caused cirrhosis. And I look back through the records and I see a CAT scan or an ultrasound 5 or 10 years ago. I said fatty liver, mildly elevated liver enzymes for years. And I say, did anybody mention anything to you? And either the answer is no, I didn't know I had that, or yeah, but they said don't worry about it.
So how can we change that? I know a little bit of the answer. We have a NASH council that it has involvement from cardiovascular and endocrine groups. With you, I'm part of the AASLD NASH task force, which is also working across those, to break down those disciplinary silos. What more can we do to make sure that whatever physician or point in the clinical process that a patient interacts with, that we sort of optimize the opportunity to have fatty liver disease or diabetes or any of these sort of metabolic issues, dealt with and referred to the right place, or just, paid proper attention to?
Yeah, it's a challenge, as you know, and that's why you do what you do. And because, it's changing human behavior. And we all know that has a lot of challenges. Physician behavior, recognition, the motivation to act on things, and I feel for the primary care physician and the endocrinologist, just managing diabetes. They're worried about the retinas and the toes and the coronary arteries and, a whole load of other things. And now we're telling them they got to worry about the liver too. And they just go, oh my God, really? So we have to make it easy for them to figure out what to do and make them aware that it's significant. And frankly, many of my colleagues will say, well, am I going to do anything differently? And I say, well, it's important to know if somebody's, getting to the point where we worry about progression of cirrhosis. So yeah, we do different things there. But what will really change things is when we have approved therapies for fatty liver disease, treatment for NASH, because then it really raises the bar for recognition in the urgency and the importance of that, because then it does change things, because they can route the patient into appropriate care channels to be managed.
So, two things that you've mentioned, though, really strike me. One is the blood tests available, and there are increasingly more ways to diagnose fatty liver disease, as well as there has been for diabetes, through blood tests and non-invasive diagnostics. You think that will make a big difference, because it does ease the workflow for both the patient and the doctor, about how, rather than going in for scheduling a biopsy and going to a different center or something. Do you think that having more non-invasive diagnostics will improve the situation and enhance these conversations?
Absolutely. No, you're exactly right there, that we do need better non-invasive tests. And as you said, we have a number of options out there now. And one of the simplest we call FIB-4, which is a calculation just based on lab tests and age. And actually, some systems I know have incorporated that electronically into the system. So you may not know this, or folks may not know this, but already when we get our lab reports, there's an automatic calculation of somebody's GFR, or kidney function, based on blood tests. It's reported out. So what can be done is we can have automated calculation of the FIB-4 just based on routine blood tests.
I think that's really important, and I know that exists since we're recording this at least on Veterans Day, and thank you for that. That's there in some of the VA hospitals. They do have FIB-4 embedded in their electronic health record, and so that does give that calculation to the physician.
Yeah, I think that's important. And then, usually those things have a little guidance provided, hey, this is elevated. You might refer to a hepatologist. You might do additional testing. And in Europe, they're a lot more attuned to these care pathways than we've been historically in the United States. And there's a lot of algorithms that have been developed actually to start with FIB-4 and go to other tests like FibroScan, and to identify the high-risk patients.
Well, you saw that work in hepatitis C, those care cascades and pathways built into EHRs, particulate centers like Kaiser, which is a more integrated health system. And so I really think that when we talk about sort of quality liver care in general, paying more attention to the order sets and the care cascades, and how we can make it easy, particularly as more and more patients will be, identified, hopefully, and even managed to an extent in the earlier stages outside of a hepatologist's office, to be able to make it, just really feasible for, internal medicine or family medicine and others. I think those alerts and electronic supports are necessary.
I agree. And I know you're very aware of our success with hepatitis C, but when we look at the rate of liver transplantation for hepatitis C, it is just continuing to plummet. So it's becoming a relatively a small reason for us to be transplanting compared to alcohol and fatty liver disease. And that, I take that as a sign of optimism. That's what we can do when we have effective therapy and we have effective screening. We've saved an enormous number of lives and had positive impact on so many people by doing exactly that.
The other thing that you started to discuss was, certainly having an FDA approved medication or EMA approved medication with a specific indication for NASH will no doubt be a catalyst. But there are things that people can do now, whether that's specific lifestyle supports of dietitian referrals or bariatric surgery or some of the diabetes medications. So what can people do now while we move towards a medication or a device or other therapeutic?
Yeah, that's a great question. And we tend to be a little bit too pessimistic in my mind about the impact of these recommendations. And I think they do make a big difference. And I spend a fair amount of time in my clinic talking to patients about healthy eating habits, about regular exercise, overcoming barriers to exercise. In terms of time, a common one is people are just busy working desk jobs. They're tired when they get home and they don't do anything. And it just has to be a priority to carve out time to get the body moving. And it does make a huge difference. So yeah, those are the seemingly simple things, but as you know, they're not so simple to actually implement, people to engage and sustain. And then the things, options such as bariatric surgery are important too. We know it can make a huge difference in terms of the liver health in the right patient.
Someone was commenting on, you can't see it from this view, but I have weights on one of my other shelves here in the office. And
Love it.
I was like, yeah, on occasion I do, put on, a video and do, 5 minutes, 10 minutes of a light, weight routine. And if I can't fit in anything else, then, that's it. But, it's something that you had to sort of strategize about how to, literally put exercise like in my way. So I have to step over opportunities to exercise to get through the day. So, I recognize that struggle, but it's so important, having come from the end stage liver disease and trying valiantly to move, back upstream towards prevention. So grateful.
The other thing, of course, is dietary habits. The other important aspect is dietary habits.
Right.
And, getting people off sugar sweetened beverages, which we simply do not need them in what we consume. And, the high calorie, high salt, the fast foods that, again, they're simply not good for us. Focusing more on a Mediterranean type eating habits. So there's a lot we can do. And, as you talk about dietitians, there's a lot of education that has to go into that. And, and it has economic impact too.
One of the things that struck me once when I was visiting an academic medical center that was doing a fantastic presentation for NASH patients, but the nutrition presentations for NASH and for transplant were back to back. And it was sort of the old or the transplant presentation hadn't been redone to reflect the fact that, as you just mentioned, that the reason for transplantation is more often fatty liver disease than it is autoimmune diseases, as it was in my case, or other conditions. And so the recommendations were diametrically opposed. So the recommendations for NASH were about really how to lose weight and how to, reduce the caloric input. And as I remember very well, having been, 85 pounds as I was waiting for my transplant, it's about add some peanut butter to this. How can we gain weight to be, strong enough and sturdy enough and avoid frailty before going to transplant? And so I saw the confusion on the patients' faces, and some even chuckled, like, if I have a choice, I'm going to choose the one with the peanut butter. And I was like, no. for a different, disease state and, and a different, path to coming to transplant. So I think that we need to, update our nutritional, education to patients and be specific. With people, I hear a lot of frustration. My doctor just told me to lose weight, or my doctor told me to like eat better. I'm like, I don't know how to do that. But, sort of armed with a diagnosis of fatty liver disease, with an understanding of the seriousness and potential urgency of this, they're willing to try, but they need a little bit more precision and support.
I agree. And I'm not a dietitian, but, in all my after visit summaries that get printed out and handed to the patient, I have the recommendation to go check out the websites for the Harvard Healthy Eating Plate or Harvard Healthy Eating Pyramid, and also just the Mediterranean diet. We have data on that it's beneficial for the liver, and avoiding sugar sweetened beverages and fast food.
It is. I am, there are certain things that we just don't keep in the house. Or if we do, people have mocked my, my cookie technique. So I do have cookie dough in the house, but it is in the, the bottom drawer of the refrigerator. And if I want a cookie, I have to preheat the oven, segment out, 2 cookies, bake the cookies, and so it's like a half-hour process. So I have to really want that cookie to have that cookie.
That gets a couple points I make to patients. You want to avoid the psychology of denial and deprivation. Right. There's a lot of literature around that. That if you focus on what you're not supposed to do, what do you think about all the time? It's the things you're not supposed to do. Right. So I just say, focus on what you should do. And every now and then you screw up, you have the cookie. That's not, whatever. It's like life, you move on. Life
So, one of the things that has, united the liver community in paying more attention to type 2 diabetes have been a couple of things. We've worked with CDC to have them mention fatty liver disease in their education about diabetes. And, we led several organizations to talk to, I roll it off the tongue being here in Washington for 30 years as USPSTF, but the United States Preventive Services Task Force. It's hard to unpack an acronym. But to update the recommendation on screening for prediabetes and type 2 diabetes to include the risks for NAFLD and NASH. And so what other things can, we work together with our friends in diabetes and internal medicine to make sure patients are screened, to ensure that the standard of care for both NASH and type 2 diabetes are evolving together. I believe that there are some guideline adjustments that may come out at some point soon to help give updated information. But how can we make sure that all the the policies and the recommendation in the diabetes world as well as in the hepatology world are reflective of what the things that we know and discuss?
Oh my gosh, Donna, I'm out in the trenches and I have a policy question. I
know. Well, here it comes down to this: is I early in my career, I went from having a very DC centric policy job to then on the next, I was a Friday. On Monday, I was sitting in front of a hospital executive, realizing how what we had done in Washington actually works or doesn't in the front lines of care. And so I'll ask it this way, maybe. What things would be helpful to you? So, as we clear out barriers, what things would make it easier for you to work with your colleagues in endocrinology or get the right care for your patients with NAFLD and NASH, either making sure it's, reimbursed or available in your system in a more coordinated fashion, or what would help you help your patients?
Well, as it was a major victory to get mention of the liver in the recent ADA guidelines for the American Diabetes Association, to say that, anybody with type 2 diabetes, as I mentioned earlier, with fatty liver, elevated liver enzymes, we should look further So, that's a big step forward. But
Mm-hmm.
I think your question drives more at, how does that actually get implemented on the ground in the
Mm-hmm.
clinic?
Right.
And it's a tough one. We do a lot of it. We do a lot of education. I give grand rounds to
Mm-hmm.
endocrinologists. And Ken Kusi is out there beating the drum, trying to bring everybody up to speed
Mm-hmm.
in the endocrinology community. But it
I
just
know
requires.
that, yeah, I know that, Scott Friedman even had, brought a fiber scan down to the endocrinologist, down the hall from him. I think the more that you hang out together and talk to each other, the more you'll realize that, you have patients in common. And so I think that those relationships are helpful. I sit on the board of a hospital, and so I've had the opportunity to ask questions from that level about what are we doing about, these conditions, and and even drawing some diagrams on some plans for new facilities to make it in. But so I think it is a whole of healthcare approach, needs to be aware of this prevalence of liver disease within so many other patient populations, and I think all of us working together can move this forward.
And of course, the patient awareness, which is a lot of what we're
Mm-hmm.
doing right now too, because I know a lot of
Right.
patients will be watching this, is asking your doctor and sort of holding them to task. Like,
Right.
What about my liver?
That's right. Read your lab results. When they
But let me
come
just
through.
mention that, Don, in terms of lab results, it's very important. The elevated liver enzymes begs the question is what is elevated for an ALT
Mm-hmm.
and AST? And we have published on this. So what laboratories report out as their reference range, sometimes
Mm-hmm.
called the normal range, is actually a population normal. It's not a healthy normal.
Mm-hmm.
And that's the population. We have a third of our population, adults, have fatty liver. That reference range will include a lot of people with fatty liver, where they got those values from. So they actually have unhealthy elevations,
Mm-hmm.
but it gets reported in that reference range. And several studies have been done looking at what is a healthy ALT, and it
Mm-hmm.
generally settles out somewhere in the 20s to 30s, or up to 30, usually lower for women than
Mm-hmm.
men. But anything over about 30 units per liter for an ALT is actually too high, probably. But we have laboratories that report out upper reference range values of 55 or 60 or 72
Wow.
even. So we end up missing a lot of folks
Mm-hmm.
if you just use those numbers. So you actually have to look at the raw number and make decisions based on that rather than compare it.
Mm-hmm.
And in busy clinicians, we look down all the results and see if anything is flagged as abnormal.
Right.
So an ALT of 50 might not be flagged as abnormal because it's within that laboratory's reference range, but it's too high. So if I had type 2 diabetes and an ALT of 50, I'd be worried.
That's really important information, and it is also important information for an organization like mine to maybe standardize those reference ranges, or ask that those reference ranges be standardized, so that because I think most patients will just look at the red,
Sure.
Are some of them red,
Right.
so now they're
Exactly.
color coded, for ease, and I really appreciate that. But if those ranges aren't really narrow enough to sort of capture, disease or sort of
everybody with
dysfunction.
disease. Agreed. That's a great idea, Donna. Now you have a new task came out of that.
Now I have a new task. I needed one. I had a whole afternoon off. The other thing that, as an experienced patient who, loves my liver lab, all of my lab results, is knowing what is, knowing what's the right level for you. So, your example of, the gender differences in lab results. I also know that, for me, this far post transplants, there are some numbers that sort of are abnormal for, the normal population, but are really great numbers, for me. So as I try to have conversations between, primary care and transplant, I'm just like, no, a creatinine of 1.5, which would be very alarming for someone not 27 years post-transplant, but it's great. For me, I'm like, that's not what we have to worry about. But I'm like, but let's look at this number. that look at that hemoglobin at 9.2. Can we do something about that? Yeah, exactly. That's where I was about a month ago. I'm like, can we do something about that? And so understanding what the ranges are, what even, the appropriate ranges for your different characteristics, whether it's gender or race, the conversation we're having in, EGFR, but also knowing what your normal ranges are so that you can, tell your doctor, yeah, but that's not right for me. Like my blood pressure is usually very low and now it's high, even though it's in normal range, that's high for me. And being able to understand what your own personal baselines are is really important.
Yeah, absolutely. And good clinicians know that, and they look at trends over time. So if somebody's in the high normal, like on a hemoglobin, and all of a sudden drops into the low normal, it's like, that's a flag, even though it still falls in the normal range. It's like, what's going on?
So we have a lot of work to do in educating both patients and physicians to optimize liver and endocrine health. So
you're
I'm
doing
glad
a great job leading that. Thanks, Donna. Again, I really appreciate what you do.
Thank you, Dr. Tetri. And thank you everyone who has watched or listened to this. Until next time, happy Diabetes Awareness Month. Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.